Great. And you will have access to this recording following this webinar. It takes a couple of days for the video itself to be finalized and things like that. But we will make sure that for everyone that registered, that you do have access to this video following the session. Now, before I turn it over to Dr. Mario, I just kind of want to set the stage on like why we're coming together. What is the purpose of this webinar session that Orange County has put together? And what has happened is Orange County, specifically the Orange County Family Support Task Force, has been working for about a year and a half with the National Center on Substance Abuse and Child Welfare to implement innovative ways to improve outcomes for families that are affected by parental substance use. And one of those ways is the implementation of what's known as a family wellness plan, or at the federal level, it can be called a plan of safe care. And as a part of this implementation, one of the things that the task force did is they stood up a work group to really dive into the areas of stigma and discrimination and how to improve access to education for healthcare providers. And so what that work group decided to do was they felt like a meaningful step forward in that space was to host a webinar series that provides information on the science of addiction, that provides information on the effects of stigma as it relates to service access and engagement, and then also a session that provides resources. There are so many resources that are available within Orange County that we want to make sure that healthcare providers are aware and have access to those resources. So what we've done is Orange County has set up kind of a three-tiered or three sessions around those key items. And again, today is kind of the kickoff with Dr. Mario, where we're going to learn about the lenses of addiction. And then Monday, we'll have a Q&A with Dr. Mario as well, which I'm super excited about. Then the second session is about the effects and understanding the effects of stigma on service access and engagement. And we're super excited with that one. We're going to have Dr. Heather Briscoe and Stephanie Jeffcoat that are going to be panelists for those sessions. So it'll follow the same format kind of as this session here. On Wednesday, August 7th, you're going to get an opportunity to hear from them about their experiences and about ways that stigma impacts service access and engagement. And then you'll have that following Wednesday, you'll have a Q&A with Dr. Briscoe and Stephanie as well. And then the third session is, again, about resources so we're excited to have a panel for that as well. We'll have Jewel Loff and April Thornton that are going to come to the table and really unpack for healthcare providers all of the resources that are at your disposal whenever you're serving pregnant individuals that are affected by substance use. So if you have not registered for these two sessions, you can scan that QR code right there, and that will allow you to register. But what I'm also going to do is I'm going to put in the chat the links for you to register for those sessions as well. So if you give me just a moment here. All right, I just put in the link for session 2, the effects of stigma on service access and engagement. And then likewise, I just put the link for session 3. So again, if you're unable to scan the QR code, you can just click on that link and it'll take you to the registration page for those two sessions. Now, what I would like to do is first, I will just tell you, whenever the stigma and discrimination work group began processing through, okay, we know we want to talk about the science of addiction. We know we want that to be one of the key pillars that we want to be a part of this webinar series. Immediately, Dr. Mario came to the top of the list. The entire work group was like, oh man, have you heard Dr. Mario? He's a phenomenal speaker. And so I had a chance to look up some of his sessions. And I would just say, like, I'm grateful, and I hope that you were excited as well to hear from Dr. Mario. So Dr. Mario, he is an addiction medicine specialist, board certified in addiction medicine and family medicine. As an addiction medicine specialist and family physician, Dr. Mario is involved in efforts to integrate substance use disorder treatment in the primary care setting. Dr. Mario serves as the medical director of the Mac Connect program in Orange County, which is a program with a mission on expanding access to SUD treatment, particularly through community clinics. Dr. Mario has been a medical clinician at all levels of care for substance use disorder treatment, including hospital-based withdrawal management, residential treatment, and outpatient treatment. And Dr. Mario is currently clinically active as well, serving patients through the KCS Health Center and is involved in applying technology to solve access problems for people with substance use disorder. So with that being said, I would like to take down my screen and turn it over to Dr. Mario.
Okay, thank you so much, Sean. Can everybody hear me? Good. All right. Well, thanks so much for having me here today. I always get excited about talking about some of the fundamentals of addiction because I think it's an area that, well, it pretty much affects everybody, even if you don't think you know somebody that has an addiction, or if you don't, you yourself don't have something. It comes up in all sorts of different ways. Everything from if you're somebody that thinks of things in terms of financial. Most of the dollar for all the kiddos that need neonatal withdrawal management comes from Medicaid dollars. So guess what? Whose wallet that is? That's yours. So I appeal to all of you from the heart. And I know this group is going to be totally kind of like, I'm going to be talking to my people here, right? You guys are all in healthcare. And so this is always a wonderful opportunity. So I thank you for that. We're going to hit a bunch of different areas here. And like I already mentioned, I don't have any disclosures, by the way, in terms of I don't get paid by any pharmaceutical companies. I don't have any sort of roles like that. You already kind of know that where some of the main areas. I'll add one or two other areas here. Is I do quite a bit of medical legal work where I serve as an expert witness. So a lot of that's advocacy, actually. Folks that die or get injured or bad things happen when they're not getting what they, are supposed to get from standard of care standpoint. And so because substance use disorders have oftentimes been in a silo, and that silo has created critical access problems and a lot of other issues. And in fact, that's kind of why we're even here, right? We don't need to do it too much for a lot of other conditions, but certainly for this one, we do. Only a small percentage of people with substance use disorders actually ever have access to treatment. So I'll say that in terms of the main objectives here, I want you to get a sense of what addiction is. And so we'll pick one here in terms of what we will discuss a bit more on, and that is the medical model of addiction. But I'm going to also talk about some other ways to view addiction. There's not just only one way that I believe is the comprehensive, fail-safe type of way to look at addiction. We want to also understand some of the neurobiology. So we will geek out a little bit. I'll put on my propeller hat and I'm going to geek out on you a little bit on, why? Because a lot of times, we hear discussions around what something is in a description, but we want to know kind of what's the background. What kind of proves it? What do we know that helps us understand this model? Does it hold water? And then I just want to emphasize at the end, there'll be lots of things we'll be talking about, but, that issue of the family wellness plan. So we're not going to be emphasizing greatly on treatment, for example. I'm not going to be giving you every modality of treatment and all the details of all that. But I will say that for those of you that see patients or have clients that you're everything from the medical to the side of case management, social work, all of you are important components of the continuum of care for families and individuals that are affected by substance use. And so this family wellness plan is actually a nice little tool you can use. And if you just use it almost as a checkoff list between you and the individual, it's actually something that's useful even if you don't know the various aspects of overall treatment. So let's start off first by kind of setting the ground rules in terms of like what we're talking about. It's important that if we say a word, we need to know what it means. And it's not even straightforward. if we look at the DSM-5, right, the big book of all things psychiatric and mental health, they don't even use the word addiction really in that, but yet we have this body of knowledge and an area of subspecialty called addiction medicine. We call things in the other books substance use disorders. In the past, we've used all sorts of language like abuse, misuse, dependence, and then there's addiction. And it's like, well, what the heck are you talking about? And so over time, you just need to know that the language has evolved, just like it does with everything else, not only for real good reasons that are like associated with just understanding a body of knowledge a little better. Sometimes it comes out of coding, in terms of, remember, you don't get anything in the United States that there's not a code attached to it and there's a reimbursement. So there's that part of the world. And then there's also another part of the world that is just trying to align less stigmatization to substance use, like we do with a lot of other things, actually, by improving our language. So there's an evolution. So, but definitions do matter. And the reason is because if we don't pay attention to it, then dumb things happen, right? And I want you to start thinking about like courts and legislators and these people that are in charge of moving resources. It's quite important that they understand, and this is why some, legislators have whole staff, and those staff go around and they talk to experts, and then they kind of collect information and they try to make sure they're talking the same language. But if you don't, then you start making dumb policies. In this case is always a funny one to me. I mean, maybe not so funny, but in Ohio, they at one point entertained this idea of the 3 strikes you're out for Narcan. And so if it's kind of a way to send a message, hey, if you're going to overdose, don't do it in our neck of the woods because you'll pay the price. Of course, you get to die, right? Wonderful, wonderful way to take care of something, right? What a wonderful public health measure. Again, dumb things come about when we're not talking about the same things. I bet probably if you sat some folks down and you said, let's talk about what exactly what we mean by these things that you're going to put in these policies, and then they'll might understand. And some of it has to do with just raw understanding of things, scientific based, but also there's this aspect of the heart. There's an empathetic aspect of it, and also a pragmatic part. How do we set policies and stuff? You can't just always be thinking of it in every sort of empathetic way, because sometimes there's other people to protect. Like in the case of what we're going to be talking about a lot today, right? And in the case of a family of a pregnant person, there's also a child, and there's an extended family, and there's a lot of other, and all of those folks are affected and at risk. So when we talk about addiction, we can look back at its root, the term addictus from Latin, and it meant it was from a Roman law that meant a debtor was awarded as a slave to his creditor. And that will sometimes be what you might hear of somebody if you have a real good discussion with them that is suffering from a substance use disorder out of control, that is not, that they're truly in their disease. They feel enslaved by it because they themselves don't want to do it. The reasons they may have started to do whatever they were doing with a substance now have likely changed. And they don't even derive anything from it except all of the negative consequences. Yet, despite all those negative consequences, there is still this impulse to go in that direction. And you have to scratch your head. And I'll say one thing: every single one of us, as people that work in some aspect of health, whether you're an administrator, a direct patient care person, a scientist, a researcher, doesn't matter. We all need to also check ourselves in terms of what it does to us emotionally, internally, and how we respond to something. Because in the case of addiction, unlike maybe high blood pressure, right? If I say, oh, so-and-so has high blood pressure, it generally doesn't incite things. But now I want you to imagine somebody that appears to be about 8 months pregnant. You see that individual on the corner holding a 40 ounce of malt liquor and a cigarette. And I bet most of us will have some sort of conjured up thing going on in our brain of some neurotransmitters are buzzing away, because we also have some kind of opinions about kind of what's going on and how we feel about it. And so we have to be very careful about that. And we have to always be, looking at that. And that's something that's a fundamental thing, all of us in this kind of setting. But we used to think that addiction was really about the drug, right? We always focus on the drug. Is it a cocaine? Is it alcohol? Oh, this person can only be an alcoholic. Well, guess what, guys? We pretty much have a really good case for pretty much it can be polysubstance use almost as the rule and not the exception. And that it's not about the drug, it's more about the brain. Of course, the drug has something to do with it in the sense that, look, we toss the word addiction around all the time. I like carrots. I like carrot cake. I like carrot juice. I like fresh carrots. I like sliced carrots. Uh, I I will never sell my body for carrots. So if somebody says, "Oh, you're addicted to carrots," or "You're addicted to chocolate," no, you're not pulling a trick on the corner for carrots. You're not going to lose your kids over carrots or chocolate. We use these terms very specifically about things, but the drug itself, it can have lots of variability in terms of what it does, in terms of in the world of what we consider to be those effects around addiction. But what we do know is that they're about the brain. And so over the last couple of decades, we've had some wonderful advances in neuroimaging, also in just kind of modeling around both positive, negative reinforcement and kind of what we see in individuals. We studied a little more toxicologic effects. We're able to connect the dots a little better than we were before. And this has been an evolving thing ever since the first moment that somebody probably, hundreds and hundreds of years ago, thousands of years ago, picked up a funny little mushroom and accidentally ate it and felt a certain way, or got some fermented something or other that had starch in it and drank it and then felt something or other, right? And then all of a sudden we start having some of these effects. So by itself though, right, these substances, they're not good or bad. They don't have personalities. They're not, it doesn't function like that. But in terms of what happens to a vulnerable brain and the processes that we call neuro adaptation, these neural adaptations in all sorts of parts of the nervous system, but particularly in the brain, that control or at least have a very significant impact on things that happen in our life. This is where the science went. So as we start looking at that medical model of this definition, I'm going to point out a few things in this definition. You're all going to get this slide, so no need to take notes or anything on this. But let's focus on a couple of things here. That addiction is a primary disease. It is not something that's secondary, tertiary. It's not something that comes up because you got bummed out, your girlfriend broke up with you, and then therefore you put a needle in your arm or you start doing all these things. It actually has its own trajectory, just like major depressive disorder might, even though you can have a co-occurring version of that. It's a chronic disease. It's not something that you go and you get treatment at, blah, 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 rehab, and then they gave you something and you're fixed. And it doesn't, that same thing for physician offices. We have some wonderful FDA approved medications that help in certain substances of use that we can use them, but they don't necessarily fix it, right? And so it is a chronic disease, though it's clear that it is treatable. Okay, that it involves certain neurocircuits that we kind of understand now that have to do with reward, motivation, memory, and these circuits, when they dysfunction, when they have some sort of a disorder, they lead to these very characteristic things, and they're in a lot of realms. We're used to biology, we're used to psychology, we're used to social, even though the whole buzzwords of SDOH and all that has been in the front page recently. In the world of substance use, the concept of SDOH has been from the beginning. That's already been there for a long time, but I'll add to this one, even a spiritual manifestation. And I don't mean religious. I mean that sometimes at the end of the day, that metaphorical rock bottom or whatever that might be for somebody, there's no biological, psychological type of thing that sometimes brings people out, where there's this spiritual component, difficult to put your finger on, but oftentimes has everything to do with connection with others. And so at the end of the day, that there's some sort of a common pathway that results in a pathological pursuit of reward through a substance, or technically also of a behavior, right? We're talking about process addictions. And we know that, again, brains are affected. We can take these kind of very interesting ways of looking at activity in the brain and metabolism. And the top two are brains, and the bottom one is a heart. And we use this example of the heart on the bottom because the heart, it actually we accept that all the time, right? We look at on the right side there on the bottom, diseased heart. Well, that doesn't look very well. Look at the one on the left, so nice and smooth. It looks healthy. Well, substances have fingerprints or so that it actually, engage with the brain as well, and for different substances. So we can start beginning to see that it's not only just like some conjured up thing in somebody's mind. The concept of addiction being a moral failing, or just simply a simple behavior change that needs to happen, or that it is some sort of a criminal type of thing that you only associate with. It doesn't hold water, because we also see some structural changes. The neurobiology begins to inform us a little bit more. Also, that brains recover. So all these folks that say, hey, just put them all on an island, what are we going to do with these people? We tend to say that over every sort of overwhelming disease that comes about. We said it when we didn't understand what HIV/AIDS was. People would say such things, the fear. But look, we know that with treatment, people do get better. People do are able to function. And remember, this is not about do you turn around 100% of the issue. It is around improved quality of life and safety. Those are two big ones in my mind. This is what I constantly think about every time I see a patient. Am I improving the quality of their life? How they define that? Is it, walks around the park with their grandson? Is that the quality of life for them? Is it function in other ways? And then, not getting arrested, holding a job, staying with, being able to stay with their spouse. And so we can even take pictures of it here. On the left side, we have a healthy control. On the right side, somebody that's 14 months in abstinence. And then in the middle, someone with less abstinence. And you could just see, just looking at the two sides, which look more or less like the other, and it's beginning to look healthy. So we're getting to see even structural changes. Now, people get caught up on this concept around disease, and you have to realize that what we mean by a disease is not that it's your fault, that you have a hand in it, right? It's more or less just, it's some sort of a cluster of signs, what you observe, symptoms, what somebody tells you, and that they more or less, if you were to put them together and observe them, they repeat. They repeat no matter where you're at, no matter what your religion, what your gender, whatever, all these variables that they more or less repeat. And we can see them over and over again. And that's how we characterize even what a disease is. So we don't have to get caught up on, is it your fault or not? Unfortunately, substance use does have that component. People, in acute circumstances, when you go to the ER and you say, I have chest pain, nobody asks you, did you exercise 3 times a week? Did you take your statin like your doctor told you? Did you control your blood pressure? What about those 50 pounds you're supposed to lose? No, you know what they do? They immediately put your EKG on. They give you the medications you need. They possibly take you to the cath lab, and they try to address the issue if you're having a heart attack. Well, that doesn't happen the same with folks with substance use. Oftentimes there's this anger issue of like, well, how is it that they keep doing this thing? It's a frustrating thing. Now, there are other ways to look at that besides the medical model. I'll throw this one in. Just, you can consider this one too. I actually think that a combination of both of these is more complete. That the life process model looks at it, that it's not a disease at all. That it's really more of a habitual response related to gratification. It's related to the security that having the habit gives you. And it's really understood more in the context of social relationships and what happens to you in life. And that's another way. Now, look, a lot of this, I believe, can be very true, but I don't think that it excludes what happens in terms of the medical model. I think that it contributes to it, and it maybe makes it a little bit more well-rounded. I'm not going to go into too much detail on this area of stigma because you're going to get a whole workshop on this. But I will just say that as providers of care of some sort, whether you're a physician, nurse practitioner, PA, a medical assistant, and also the staff and others that are involved in the care management, social workers and case managers, psychologists and therapists of sorts, we all have to be able to use professional language. And so there's an ongoing approach to that. And, maybe one of the clearest ones in the world of substance use is around something like when somebody has a urine drug test that shows an abnormality, that somebody says, well, your urine's dirty. You're dirty. Or you're either clean or dirty. This, this is kind of an example of kind of some of the things that we want to at least start moving away from, because that it's not helpful as we try to use this in the context of a condition that we can actually treat. And then just some in terms of even accuracy, IV drug users or addicted babies. Babies can't be addicted. We'll go through this idea of the definitions. That's why it's important. And in the context of family and perinatal considerations, really one of the other things that I'll just toss in, we're not going to go in a lot of detail on this, but is, there's this burden that we can look at, and it's this non-genetic. It's not one that you inherit through the DNA, but it's this intergenerational transference of all those issues that come up around substance use. And you can see them certainly in isolated populations. You go to Appalachia, these areas where you see generation after generation after generation. When we treat substance use appropriately in families, you change generations moving forward. You also change their ability to maybe want to go to school, which changes their socioeconomics. Socioeconomics are linked to outcomes in health overall. There's just so many repercussions in all directions. There's just massive arguments. And it also helps inform us of, well, what do we need to be focused on? So when somebody's pregnant, they're in this prenatal period, we have this opportunity, whether they've had experience or not in terms of substance use, whether they've engaged in certain types of treatment or not, what do they need? What do we do to stop that intergenerational transference? It's part of what the issue is, right? Which also begs this question of, well, who's the patient then? Is it the family? Is it the individual that's pregnant? Is it the baby? Who's the patient? And to some degree, everybody. They all are. They're all. You cannot exclude one. Really, if you want to be comprehensive about the end outcome of what we're looking for, that quality of life and safety. And so we see this as well in patterns where 50% or more than 50% really of addicted parents are they're just repeating patterns. So this is an important kind of concept. Now we are moving in terms of what is appropriate treatment. It is moving over time to these focus around family and systems, and not so much around just the individual, and not only for just the adult, that you must really be concerned about protecting that infant and then the brain, right? We said it's about the brain. Well, it's about the brain. There's also a time area. About 80% of all people that as an adult have active addictions, they started in the pediatric age. So really, this is almost a pediatric condition practically, right? Where do those traumas, where do those impacts, where do they happen that then cause for coping in a brain that's not prepared to cope with these types of stressors? Yet they have to come up with something. And so they do, and they generally are these, nasty things that folks have to endure in life, and even in terms of co-occurring disorders, may or may not even involve substance use. And later on, we'll talk a little bit about some examples. But other complications that we can, point towards in pregnancy that are important, right? Besides just the regular old comorbid medical, right? We're talking about all the things that somebody comes into a pregnancy with just in their background, but some psychiatric issues. Can they take meds, not take meds? They have potential premature labor, abruptions of the placenta, and then lots of concerns sometimes around violence, and in the home. And so these are some complicating factors. For the infant, there's these issues around teratogenicity. Is the exposure that they got to some sort of chemical, is that something that also looks at impacting their development, and really in some cases their whole life, right? Folks with fetal alcohol syndrome don't just have it for a week. And so some of these are quite well understood, and some of them we're still understanding, like around opioids, for example, where there's some areas where we get some concern, and it becomes an issue of weighing risk and reduction of risk, as well as harm reduction, and then trying to do the best we can from that standpoint. There's also the traditional things that we see a lot in substance use around exposures to infectious diseases of all sorts that can be quite significant. Neonatal opioid withdrawal syndrome and other types of withdrawals, including from benzodiazepines and alcohol, which are kind of these what we call GABAergic type of processes, and then all the social things that many of you are very aware of. And then later on, you're going to learn how to connect the dots, because part of what determines the the outcome in terms of a good outcome for this family to be healthy, to stay together, and be safe, and to not be injuring the infant and all these things really is predicated around the massive amount of support that these folks that have these parents that have substance use disorders are going to need. They're going to need it. And it doesn't have to start at some big massive program. It could start in a medical office in terms of what gets offered. And in this state, we have things like CalAIM and other things that, depending on the insurance, that begin to address some of these. But they're all very, very important. And I already mentioned stigma being one of the big ones, because that same individual that might have conjured up these ideas I told you about, that 8-month pregnant individual holding the 40 ounce of beer and the cigarette, they're getting judged, and they know it, and they often will not show up for care. They're fearful that they're going to not only be prosecuted themselves and feel enslaved already by the substance, and then on top of that, they fear that they're going to have their children removed just by a matter of fact. And then it's not a pleasant experience when somebody doesn't understand substance use, but then is involved in other aspects of your care, which can become traumatic in and of itself, to engage in the healthcare system where that is what you expect. Nobody's necessarily caring about you. Every time you show up, that person's thinking you're a liar, you're a manipulative, you're this, you're that. And in the meantime, you might have had an appendicitis, but they're just thinking you're drug seeking and this and that. I mean, it happens every day. And I told you about all those medical legal cases that I do. A lot of those medical legal cases involve that. Okay. And so part of what we hope to learn here and to communicate is to think it through as just like you would in another chronic illness. And those same individuals that you might think, oh, this person's drug seeking and they're trying to get one over. Guess what? Even your little old lady that you're giving an ACE inhibitor for high blood pressure, she's not telling you probably the whole fact of whether she takes it every day. Studies have been done in terms of the accuracy of people reporting back to the compliance of what we ask people to do. But somehow it's generally a factor. And sometimes, guys, you can just see it in somebody's face. Okay, the story. That story that at 28 they start using something, get exposed. At 29 they may get engaged in the child protective services process, lose their kids. At age 31 they might meet an unsavory person in their life and start being pimped out. At age 32 they get they're homeless. They don't have any sort of employment. They're dependent on very, very shady characters. 33, 34, they're now hepatitis C positive or HIV positive. They're getting cachectic. They've lost their teeth. They can't eat well and feed well, and then they die. We called it a disease, right? Because no matter where you're at, these overarching things that happen in the presence of the substance, they keep repeating. And so these things are kind of more or less predictable. That's kind of what we mean when we talk about a disease. And of course, we talked about the DSM-5. And you can look at some of the details. Take out opioid and just substitute whatever substance you want. You're going to get an overall idea. But there is a definition for what we consider to be meeting criteria. You can look at this on your own time. But and look, these change as well. But the general idea is this around this compulsion that's difficult to change. You've tried to change it on your own. You haven't been able to do it. That you keep spending more and more of your time seeking the substance, despite negative consequences, continues to go, may or may not involve tolerance, which means more of the substance that you need to gain the same effect, or withdrawal, that when there's no substance present in your body, those neural adaptations that we discussed earlier begin to make you pay a price. And generally the price that you pay is the thing you took it for in the first place. So if part of what you were coping with is an anxious kind of disposition, maybe something you may have had some issues happen to you early on in life, and that's how you coped. You found this substance like a benzo or alcohol, and you start coping with it in that way, or an opioid. These are kind of more or less like downer type things. Well, now when you come off of it, and you're in withdrawal, it's going to give you that at 10 times what you ever could have expected. You will be heightened. Your nervous system will think it's in fight or flight. You won't know the difference between death or dying and withdrawal. And they all have characteristics that are a little bit unique to each other, depending on the part of the nervous system. So this is a very much an oversimplification, but I think it should drive the point, just that it's a big deal, and it does drive some of the behaviors. Among pregnant and postpartum persons, we've seen an increase in some cases in terms of the rate of change. This is more of a rate of change, not so much overall compared to background, but over time. And so it's very much important for us to not only discuss the recovery part, which is what a lot of us spend a lot of time on, is recovery part, right? So there's all these programs and all, but there's also the part of just like, can we keep you alive? Wouldn't that be nice to just keep you alive as well? And that's the part of this overdose epidemic, right? That has a lot of things that are attached to it. We'll discuss a little bit about that. Also, fivefold increase over the last decade or so of neonatal issues and withdrawal syndromes that require lots of resources. And we have yet to see all the details in terms of the impact in terms of development. However, certainly not as bad as when uncontrolled. So when in treatment, including medications, it can be very predictable. It could be like landing a plane versus a haphazard type of a drop from the sky. The use in terms of adolescents as they, in these families, as well as, again, there's the burden of the risk that's high, that's intergenerational, and it's real. And so we're looking at a lot of, information where there's a lot still of drug use, even at very early ages, and continue to go up and begin to kind of graduate out to things like just plain old misuse of things that aren't even traditionally associated with any sort of like trying to get high type behavior, but there's like just high risk behaviors that in these days carries a different type of potential conflict. We've also kind of collided, and this has been magnified with COVID-19, right? We have social isolation, exacerbation of mental health issues, decrease in access during that time. We had a little bit of improvement in access to telehealth. Oops, sorry, to telehealth, but not completely. And so mental health still remains one of the big areas. And in some conditions like bipolar disorder, you can have up to half of the folks with bipolar disorder having a co-occurring substance use disorder. Very, very impactful. But let's kind of zoom back in. What is this all about? It's still all about family. We're back to my initial premise of addiction, and addiction medicine is an extension of family medicine and family. It is always still about all that, and that's why it's so complicated. It's so frustrating, but can also be very rewarding to see improvements. And so, we have to kind of realign our thinking. We also know that sometimes my patients, folks that have substance use disorders, can sometimes make it very difficult for themselves in the healthcare system, right? We know that. And so, but we're the professionals. So it's actually our responsibility to have a way to tease apart and to maneuver through, sometimes even when there are aberrant behaviors, and knowing when to do certain things. Something as simple as, hey, how about you not do the 2-hour intake assessment when the person's in active withdrawal? How about that? Because you're not going to get a good result. And there's going to probably be some tension. And there's probably going to be some F-bombs, being hurled at people at some point because they're not stable at the moment. Again, nervous system is in fight or flight. Pretend you're being chased by a pit bull. Is that the time you're going to do, somebody does an assessment on you? No. So these are some basic things around the care of these folks that we have to kind of look at. Because actually, it's quite logical to be unstable when your nervous system is in that. It's not even illogical. So what's going on in terms of some of these stats, right? We talked a little bit about some of these overdoses. When we were talking, around, we had about 100, up to almost 112,000 at one point reported. Some provisional data showing some of the overdose deaths, primarily driven by opioids, but we'll talk a little bit about that. So you can see this graph. This is just from January 2015. And it keeps going up despite what we're doing. If we look at this diagram here looks at the 4 waves of the opioid epidemic, which just happens to occupy a very significant area. And I'm not saying that opioids are the only one, because let's keep it straight. If you have about 100, 110,000 plus whatever folks dying of overdoses, when we compare that to the burden of tobacco, that's like 500,000 people. If we compare it to the burden of just alcohol, to all drugs combined in the other graphic, you're at about 100,000 anyways, between 95, 100,000 people that are dying. So we have, it's not about illicit. It's not about, it's not about any of those things. There's a lot of the burden. We would approach them differently. And, that first wave being the first around prescription opioids for pain, and you've probably seen movies about that. Second wave being, hey, we're cutting off these prescription opioids, and now everyone went to heroin. They're looking for cheaper options. Street things started coming around. Consequences around injection use, public health issues became apparent. Wave three around issues with fentanyl became, more marked. You could see the graph of this blue line at the top, fentanyl. Look at that; it's almost straight up and down. And then where we're at now, where it's fentanyl plus psychostimulants. And you can see that's the last line here, red. We're not out of the woods with it, even though back in the 70s and whenever different eras, there's both cocaine and methamphetamine and other psychostimulants occupied, different stories in terms of the impact in the United States fabric. These are still very much an issue for overdose deaths, driving overdose deaths. So we could see here another graphic here of the fentanyl again here, and the two lines below that the slope of the curve is going up, psychostimulants. Okay, so it is still a big deal. And I'm not going to spend too much time more on the geeking out on the graphs, but let's turn ourselves a little bit to some of the neurobiology. We talked about that. We said first, hey, there's this kind of model we can look at it through this lens of looking at things like a disease. Even though there's these other models too that maybe complete it at the end of the day. If we came up with another name, some whatever name, that if you were to scrunch them all together, maybe they give even a more complete picture of things. But neurobiology certainly does tell us something. And in most of what you need to know here is that we do understand where some of this is coming from. And there are pathways, these dopaminergic pathways. So this neurotransmitter, this chemical communication tool called dopamine in the nervous system is mediating some of these. And it happens to be one of the most difficult things out there because it exists in some capacity in terms of some of the neurocircuits for the most primitive parts of what we are as humans, controlling things like our desires for food and water and sex, or the procreative push. Even other things that some of the ways that I like to explain it sometimes is that this concept of mama bear, what a parent does in general when they're well adjusted, not when they're on substances. They don't even make sense to do. They're so dramatic that they would do, and that's why we fear Mama Bear, right? Even in the animal world, because traditionally she would just walk away if she heard you coming by. But if she's with her cubs, she's actually going to hunt you down and kill you. Uh, Generally not in their normal behavior. They risk getting injured anytime they fight and all these things. So again, it doesn't make sense. If we look at a part of the brain, there's this little grand central station little area of the brain called the nucleus accumbens. And this is kind of like if you were to split your head right down the middle. And these are dopamine pathways. And so the ventral tegmental area, the nucleus accumbens, again, very much what we understand addiction, where this gets activated and dopamine gets released. We know kind of what happens. And part of that, if you look at the last part on the upper left side, the prefrontal cortex. And this is the part that we're going to connect again. Our frustration sometimes is people that see individuals that make choices like, hey, Jimmy, you just got out of the ICU. You were intubated for 3 days. You just got out. And then you're 2 days out from the hospital. And now you got busted again for like trying to score some heroin. What's going on, man? Why can't you get, this is our brain starts, because that's logical, right? You should learn from negative things happening to you, but for some reason it doesn't. And then we look at this prefrontal cortex that controls judgment. That's the executive function part of the brain. So when you get these dopamine pathways activated, it's almost like you're cutting off the good function of the prefrontal cortex. So now I want you to imagine, why would you ever have that? So we're back to Mama Bear. Well, you want there to be, things that get rewarded that are basic, primitive, lizard brain stuff. And that's the neurocircuit it hijacks. It obviously is not there for methamphetamine, right? That's not why it's there, but it happens to hijack it. There's some substances that can cause changes that are self-reinforcing in these areas, resulting in dopamine being released, and then basically that prefrontal cortex stops working. which begins to give us insight into the bad decisions or the non-useful decisions or the hurtful decisions that sometimes happen when people are in, well in their disease. And if we can even take pictures of this development when it's cooking, somewhere in that, early 20s, it's baked, right? At that point, you're cooked, you're good. We expect you to be pretty well adjusted. But at 6 years old, I don't. What I expect from 6-year-old is different from that 20-year-old. Now, if you experience something traumatic or a kid exposed to substances, these substances that can cause these self-reinforcing addictions, well, then what happens is you arrest development of this prefrontal cortex area. And we all know that person that's 45 years old that still acts like they're 16, still making the same kind of decision, never quite snapped out of it, still kind of and it's part of it is because they did kind of arrest development. And sometimes there's these unresolved traumas that kind of keep us back, but may or may not even involve substances, but it can happen. And of course, I'm way oversimplifying. There are more neurotransmitters than just dopamine. And also these areas around I mentioned before around memory and learning and emotion, the amygdala, the hippocampus, these other parts of the brain that are very important for that. They're also involved, as well as receptor systems and families like opioids, and all of these are important ones that again, if you like to geek out like me on these, and we can sit down one day at a Starbucks and geek out on some of these, but I just want you to know that they're there. They're there. We do understand a lot of them. We don't understand everything for sure. But we know that there's these associations, and it does help us inform how do we approach treatment then. If we were to put a catheter in the brain of a mouse, right at the nucleus accumbens, that grand central station I told you about, and measure the dopamine release and go, well, let's kind of see what happens. This is the percent of the basal dopamine output. And we look at it and we go, well, what about if we expose them to food? It goes, oh, okay. It goes 150% above the basal level. Okay. So we know people like to eat. I'm a foodie. Well, now sex. Now it goes to 200. We go, okay, people will pick to have, a bologna sandwich over some, they will forego the bologna sandwich for some nookie. We get that too. These are the driving forces of things that are quite potent, powerful. We make all sorts of weird decisions on. Now we start putting these other substances, again, 200%, almost, cocaine, 300 and something percent above. These are going high. They're higher than these basic things in life. Okay. Not biologically fair. We could look at amphetamine, over 1,000%. Again, not biologically fair. The nervous system was not set up to be able to have these kind of signals. It's not homeostatic. It's not, in terms of balance. And so, this is what we're up against, though. If the part of the nervous system that got hijacked is like the mama bear part of the nervous system, look, there's not many forces in the whole world more powerful than mama bear. People, we've seen the example, and of course, guys out there, there's a papa bear, version of this too. I'm using it as an example of kind of a metaphor. We can all probably relate to this, right? If there's the darndest things, is like for when things are going right. But we do know that also if you lesion those parts of the brain, they alter that whole thing. And so in the case of chemicals, it's almost like another way of lesioning it. A lot of times we focus a lot on positive reinforcement components when we talk about substance use. So, again, this might fuel the thing. Somebody's pregnant and they're using a substance and it really bothers people. She's getting high. How dare her? And so we focus a lot on this whole like someone getting high type thing. Of course, there's more to it, right? There's certain behaviors and exposures to others and all these things that will also feed that. And they're very real. However, by the time usually they get into the system or they're in front of someone like me, generally they're past that part. And really where they sit is in this part over here, negative reinforcement, which means not I'm trying to get high, but I'm trying to not get sick. And it drives a whole nother part of the brain that, again, very much fight or flight. There's even some neuroendocrine components to it, cortisol levels. There's all sorts of different things that complicate this, but it becomes more and more significant in terms of what causes neuroadaptation. The neuroadaptation is that. So sometimes, like I have patients that they may have been stable on a medication I'm giving them for opioids and for a year, 2 years. And then all we do is talk about, all right, hey, it's going to be time for, we're going to taper you off and this and that, or whatever. And we start talking about withdrawal, and they could be perfectly stable. And you'll see a little bead of sweat coming down their side of their head. They start getting anxious, their heart rate goes up. They get a little sweaty, even thinking about, what kind of may have been a traumatic experience of the experience of withdrawal to their nervous system. And so we know that those negative reinforcement properties, they do things to us in terms of our abilities to, the drug taking neuroadaptations cause generally when you take the drug, you're relieving that negative emotion. That's what you get from it. It's not you're getting actually a positive. In fact, some of the very characteristics, as you dig deeper and deeper, you lose the capacity to feel, reward. And so the dopamine, in terms of the upregulation and downregulation of receptors, and it makes it more difficult for you to experience reward. And so, even if you stabilize somebody in that process, there's still a lot of work to do to help somebody understand how they engage with what is reward. And I'm not talking about reward like money. Again, primitive, basic stuff. And then how to cope with things, how to be able to also look at nuances in their behavior to improve that executive function. So self-regulation, another important one. We start talking about parenting classes around coping skills and planning these very basic things. It all needs to be part of a treatment plan. The idea of even being flexible or salience, and then these all become impaired by that process of neuroadaptation. And we talked a little bit before about some of those traumas and things like that. Well, you all probably know about adverse childhood experiences, right? And so these are part of it. These are part of that. There are lots of ways that it could happen, and how one interprets it. Quite complicated. How we form those. Again, those areas of the amygdala, the hippocampus, they kind of store some of these things as well. And then we are forced to cope. And if you have to cope at a very early age, the thing that you came up with is likely to be not very adequate. And then you take it into adulthood, and then it's still not adequate, only now you have bigger consequences. So there's a lot to do in the long run. This is why it's a chronic illness and not just like a one and done. It is not about the substance. If I detox somebody, I'm going to say that in air quotes, what we now call withdrawal management. If we detox somebody, um, did I do anything? Is that treatment? And actually, I'd say this is after me being one of the main directors for lots of detox efforts, hospital-based, outpatient. No, I didn't. I didn't do anything for them, except for I safely shepherded them. I separated them from the substance, because some substances you could die from withdrawal. Okay, so we take care of that. We use our medical chops to be able to take care of that, to stabilize the nervous system. However, I didn't do anything for treatment. So this idea that you detox somebody and then you send them out. So if she's, wherever she's at in terms of her pregnancy or postpartum, that you just detox them and they're supposed to be okay after that. That's nonsense. We've proven it over and over again. There's so much more to that. That needs to be done. This is why we have to approach it as a complicated, chronic way. And along those ACEs, you can predict certain things that are not even drug related, right? Suicidality, and issues with cardiovascular issues, heart disease. As you add up these ACEs, they inform us to more things that can impact the life of a family and an individual. And the landscape right now, as we see what is drug use, remember, like, take back to the hippie days, right? The 60s, free love, some heroin around that time, lots of marijuana, maybe some LSD, some psychedelics. That was one level of in terms of the potency of what existed then and the kind of problems that existed. And over every decade almost, it's like we have this new thing that emerges. And I'll tell you right now, because I pretty much have my finger on the pulse of where it's emerging. There's a whole cluster of new chemicals that are coming around that are changing. We talked about the four waves already, but they're also linked into this idea where you don't have to be addicted anymore to be affected. So you know what? Even as we start talking about addiction, is that the whole thing? And it doesn't, and it's not usually just one substance, but now we are introducing even terms like poisoning, right? So a 12-year-old kid thinks he's experimenting with this thing that they call ecstasy, and he thinks he's trying it for the first time. And then no, it's actually something else like fentanyl, and it's a one and done, and they die. And they die of being poisoned. They were never had the opportunity to become addicted. They never really even almost had an opportunity to misuse anything. And this is a different kind of a different time. We had the DEA putting out, safety alerts around kind of these fake prescription drugs. People are making pressed pills in their garage and selling them. We are having all these efforts around overdose because remember, overdose, even if she might be pregnant, but if she overdoses, you still use the same tools. A lot of people think, oh well, what if you put the baby in the withdrawal by giving them Narcan or Opfi or Cloxato? These are chemicals that are antagonists. They're kind of reversing agents, or so to speak, of opioids. And you say, well, that might happen, but you know what? It's better to be alive. So we still do it, and even when we're not sure it's opioids, so whole line of discussion and understanding around kind of our approaches to stuff. But this is kind of an unfortunate thing. To me, this is like if you wanted to treat diabetes, you build the amputation center and you start handing out, forms for people to get amputations. It's like they already overdosed. What did we do before this? What did we do way before this? And because this is just let's keep you alive. And that's important, very important. I spend a lot of my time with that. However, I think that it's, when we start thinking about treatment plans and how do we assist somebody that's pregnant and has all of these variables that are social, very vulnerable time in their life, very vulnerable position, lots of stigmatization, the variability in terms of ease of engagement of the multiple types of services that they need to be able to keep it together. And a lot of the changes that happen as they're bumping into very varying levels of sophistication of understanding addictive disorders in the people that they meet. So again, I'm going to toss in one of the other newer ones that are maybe you start beginning to see also. Is this a chemical called xylazine, also called trank or trank dope, zombie drug. You might have heard it. It's actually not new, but it's we saw it in places like in Puerto Rico first, and it's oftentimes now in some parts of the United States, it can be found in up to 80% of any seized drug that they find. And you think, well, is it an opioid? So, no, it's not an opioid. Actually, it's kind of related to a chemical that a lot of us, prescriber type people do use sometimes, like clonidine, which is and even a detox related type medicine for opioids, lofexidine. But it's used for large animals. It's a veterinary medicine. It's used for like moose. But why is it there? Well, people are doing what they always want to do. And this country is very entrepreneurial. They cut. They try to take $1,000 and make $10,000, and they have to toss in a bunch of other things so they don't have clients that say, "Hey, I didn't feel anything from that." But of course, these are not chemists, and half the time it's just being done in somebody's garage or bathroom, and they're adding all these chemicals to it because they're cheap, and it can amplify. And then you get this situation where in on a 2 block radius over a weekend, three or four people overdose and die. And that can happen from some of these chemicals like xylazine, which also has brought in other things too. And these xylazine positive overdose that have been found, in terms of the regions, you can see like in some places up to 1,000% increases over the last couple of years. And so it's very real. It's making its way it's actually already in the West, and we already have it even in Orange County. It's just not as much as like places like San Francisco or certainly not like the East Coast, maybe the hub of which would be like Philadelphia. If you get a chance, go to YouTube, type in xylazine in Philadelphia, and you're going to see like whole encampments that actually have people that suffer from it. And you can tell who's who because you will see wounds, necrotic, dying tissue on their body. That is one of the side effects that you can get, besides being very sedating and causing people to be additive to chemicals like fentanyl, where you just die, you stop breathing. But very, very impactful. Now, okay, I just grossed you out with that picture right around lunchtime. I apologize, kind of. But let's take a step back. So, we talked about the definition of addiction, so we speak the same language. We talked about it being about the brain, not about the chemical. Don't focus on the chemical. But that there's these different ways to view it. There's that medical model way, and we know that along that line, there's a bunch of other things. So particularly in the vulnerabilities in pregnancy, it doesn't just stop when somebody delivers. There's a whole body of science around postpartum. And then guess what? All the developmental periods of time that follow that. So we have to be on the hook the whole time. This is not just like a very temporary thing. And it pays off. Okay. It pays off very, very much. And so at the end of the day, we still, even after we go through that receptor physiology and blah, 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 chemical neurotransmitter and all these things. Maybe that part's more for those of you maybe are physicians or NPs, PAs. You might need that little bit of extra justification in your head to understand the concepts around that, to wrap your mind around it and go, okay, I think I get this now. I get this kind of way of viewing a disease. So it doesn't just piss me off that somebody's doing these things or they're not being compliant or whatever it might be, because we still have a lot of folks that are kicking people out of their clinic or doing whatever it is when, you know what, in my patient population, when things aren't going right, I know it's part of the disease. And so what they get is basically a bigger hug. They get a stronger hug. I tell my patients, you're going to get a bigger hug. I'm going to pull you in closer. Means I might have to monitor you a little more. We're going to talk a little bit more. We're going to expand the team. We're going to try to figure out other ways, maybe mutual support, peer support type people. We have to expand what we're doing, but not the opposite, because when you kick somebody out, even metaphorically, you just stop addressing it. The price that we pay is tremendous, not only from the standpoint of the individual and the family, but in society. I've done analyses for health plans on what happens if they avoid a certain kind of combination of milligram morphine equivalents, certain things that happen in their life, and this and that. And it's, what, it doesn't even make financial sense for those of you that don't care so much about the people, but care about the finances. Um, and because we do need to look at that too. There's not endless resources. This is we're going to be up to somewhere around $1 trillion in terms of the cost of the burden on addiction when we start looking at all these areas, which can include productivity for work, and there's a litany of things in terms of the medical and non-medical. So at the end of the day, what are we still talking about? We go back to this. We're still talking about a family. We are still talking about many vulnerable risks. And so this is what you should still focus on, even though we've talked about all that geeking out kind of stuff. And so there are concepts around comprehensive care. They do involve medical, non-medical, educational, legal, and everyone right now is still kind of in a bit of a silo. We still aren't at a good place, except we have some kind of pilots in places like, within counties, for example, that people get together and they talk. DA talks to the public defender, which talks to the school probation people, which talks to some of the groups, prison reentry folks, all these things, and we're beginning that. FQHCs, I love FQHCs, right? Because to me, that's like they're the kind of the heartbeat of the system that is there to be a safety, particularly in a county like Orange, where we don't have like a big USC or even or like a Harbor UCLA kind of a circumstance. So very comprehensive. And I'll, draw our attention before I end here to, you don't have to this family wellness plan. You don't have to know all things about treatment for your patient. If she happens to, be using substances, you do appropriate screenings, which is a whole nother discussion. Screenings that you implement in your primary care setting or even in your specialty settings. What is there? And then know when to, be able to impart things using motivational interviewing, and then connecting them with the right resources, which you guys are going to get some lectures on later on. But if you know nothing about any of those levels of care and all that stuff, you know what? Pick up the document. It's online. It's a family wellness plan, Orange County. We have a wonderful leader in the county, Diana Daly, who I know drives a lot of that among, I'm sure, other folks that are doing the same. And we use this at the clinic as well. But any person that's pregnant that has any sort of substance use or risk of, and even if there's just potentially even a risk that we will fill this out. And this document has basically lots of little check boxes that you could use as a proxy for kind of the knowledge of what are the areas that I need to be making sure she understands, and then your clinic or your whatever your facility, your organization understands that they might have, because it's a multi-team type of approach. Not any one individual is the whole thing. Not the doctor, not the social worker, case manager, or whoever might be involved. It's like it's everybody. So that's where a plan gets made. And then also engaging the individual and decreasing the likelihood that when they get to go to a point where they deliver and they're able to hand over this information to maybe the social worker or whoever, in case that's engaged, that somebody sees, oh, this has been organized. This has been thoughtful. This is exactly what you're supposed to do. This is going to protect the infant. What else do we need to do to assist you? Rather than, oh, this is a bad situation. You're going to have to, your kids are going to be taken away. Or in some states, there's even, prosecution risks and all things like that. So I would really encourage you to pick that up, use it. And I look forward to Monday when we get a chance to answer a bunch of your questions. And I hope that at the very least, you kind of have this idea of addiction. We more or less talked about some of the neurobiology, how that justifies some of what we discussed around the medical model. And then also this issue around these family wellness plans. And remember, it is about the family. So thank you so much for allowing me to jabber at you. I hope I didn't put anybody to sleep. Thank you.
No worries at all. Thank you so much, Dr. Mario, and lots of content. And again, you can see why we want to dedicate an entire hour for Q&A. And again, just as a reminder for everyone, next Monday from noon p.m. is going to be an opportunity for you to come off mute, to unmute your camera, and have a dialogue with Dr. Mario around some of those pressing questions that you have in regards to serving families affected by substance use. Just as another reminder, if you have not registered for these session 2 and session 3, again, there's the QR code to be able to do so. The link is also in the chat. And then the final thing that I will say is just, again, we've talked about the Orange County Family Support Task Force. They're really the ones that are driving this effort from a collaborative standpoint within Orange County. So they've just recently released an updated brief that really speaks to the work that they're doing within Orange County around family wellness plans. So you have the ability to scan that QR code, and that'll take you directly to that brief so that you can look at it online, you can download it, you can share it. So again, I encourage you to do that. And if you're interested in learning more about the task force and the work that they're doing around family wellness plans, again, Diana Daly and Kristen Stitz, they're the co-leads for that task force. So their contact information is there, and it'll also be in the slides. Apologize for keeping everybody 8 minutes over, but as you can tell, man, the content was worth it. So thank you so much, Dr. Mario, and everyone. We look forward to seeing you on Monday. Take care.